Welcome to the deep dive. Today we're tackling something incredibly common, yet profoundly complex. Quitting addictive habits.
Yeah, things like smoking, alcohol misuse, vaping,
Yeah.
behaviors that, so many of us or people we know grapple with.
And it's so easy to frame it as just willpower, isn't it? But the science tells a different story.
It really does. Our sources, health organizations, scientific literature, clinical guidelines, they all point towards these habits having deep neurobiological roots.
Exactly. So our mission today is to go beyond that surface level. We've done the digging.
hmm
The goal is to give you, our listener, a really comprehensive science-backed guide, understanding action, and maybe more importantly, finding strategies for lasting freedom.
Yeah, let's try and make sense of it.
Okay, let's unpack this.
So where do we start? I think the foundation has to be the science,
Right.
understanding what's actually happening inside the brain.
Right, the brain's reward system. Now, this isn't some, villain in the story. It's a natural network.
Totally. It involves areas like the VTA, that's the ventral tegmental area,
Yeah.
the nucleus accumbens, or MANTAC, and the prefrontal cortex, the PFC.
And its job is basically to get us to do things we need to survive, like eating, connecting with others.
Precisely. And dopamine is the key messenger here. When we do those essential things, dopamine gets released, signals pleasure, and basically tells the brain, hey, do that again.
A biological pat on the back. Makes sense.
But here's the twist. Substances like nicotine, alcohol, they don't just participate.
They crash the party.
That's a good way to put it. They hijack the system, causing these huge dopamine floods. We're talking like up to 10 times the normal level sometimes.
Wow. 10 times.
Yeah. And alcohol, for instance, directly stimulates those dopamine-producing neurons. That surge reinforces the drinking behavior.
So what's the consequence of that constant massive stimulation? The brain can't handle that, surely.
No, it wasn't designed for it. One major outcome is that natural rewards start to lose their shine.
Things that used to feel good just don't anymore.
Exactly. It's called anhedonia. The inability to feel pleasure from everyday things. The brain basically gets rewired to prioritize the substance above all else.
That's a profound shift.
It really is. And it underscores a crucial point. Addiction isn't a moral failing. It's a brain disorder where survival circuitry gets rerouted.
Okay, so the reward system is hijacked. How does occasional use then become this automatic, compulsive habit?
It involves habit learning. Strong links form between cues, situations, feelings, times a day, and the act of using. Think Pavlov's dogs, but for substance use.
So a certain place or even feeling stressed can automatically trigger the urge.
Absolutely. That's classical conditioning at work. A neutral cue gets paired with the drug's effects.
And it shifts from being a conscious choice, like I want to feel good, to something more automatic.
Precisely. We move from goal-directed actions, seeking pleasure, to habitual actions triggered by those cues, sometimes even if the pleasure isn't really there anymore. Some researchers even call habits these sort of adaptive self-sustaining networks.
Adaptive in a way that's not helpful here. What's happening neurologically during this shift?
Control moves. For alcohol, decision-making might shift from the prefrontal cortex to the basal ganglia, the brain's habit center. For drugs, generally, it can go from the ventral striatum, linked to reward, to the dorsal striatum, associated with those automatic behaviors.
And those cues become incredibly potent then.
Hugely potent. Even seeing a logo or the shape of a vape pen can trigger intense cravings because of those learned associations. You hear stories, right? Someone quits for years, walks past an old spot.
And bam, the craving hits.
Exactly. That's the power of those embedded triggers.
Okay, so the habit is formed. What about tolerance and dependence? We hear those terms a lot when people try to stop.
Right. Key neurobiological changes. Tolerance is when your brain adapts and becomes less sensitive to the substance. You need more to get the same effect.
Your brain's trying to compensate?
It is. It might reduce the number of receptors or make them less responsive.
Independence, is that different?
Physical dependence is when your brain and body have adapted so much they rely on the substance to function well, normally.
So when you stop,
That adapted state is disrupted, leading to withdrawal symptoms. That distress, anxiety, cravings, physical discomfort, that's withdrawal.
like with nicotine withdrawal, people talk about intense irritability and cravings.
Exactly. Nicotine actually increases the number of nicotine receptors.
Yeah.
When you stop, those receptors are suddenly empty, signaling distress, driving cravings and anxiety. Areas like the interpeduncular nucleus are involved there.
So you go from using to feel good to using just to avoid feeling bad?
Precisely. The motivation flips from positive reinforcement seeking pleasure to negative reinforcement avoiding withdrawal.
And these brain changes stick
They're
around.
persistent. That's why addiction is considered a chronic relapsing condition. The brain remains vulnerable.
It's not just the biology, though, is it? The psychological side matters too.
Oh, absolutely. Conditioning is huge. We learn associations between the substance, the act of using, and all those cues, times, places, people, emotions. Operant conditioning, learning through reward, reinforces it powerfully.
And those cues then trigger really intense cravings.
They do. And our attention gets skewed.
How so?
It's called attentional bias. Your brain starts prioritizing, focusing disproportionately on anything related to the substance.
So overcoming it means unlearning all that, developing new coping skills.
Exactly. It requires actively unlearning those associations and building healthier ways to handle triggers. You have to consciously disrupt that habit loop.
Right. Remove the cue, resist the urge, replace the behavior.
That conscious effort is key to breaking the automaticity.
So putting it all together, why is quitting just so darn difficult? It sounds like this perfect storm.
That's a really good way to describe it.
Yeah.
You've got the altered brain chemistry, genetic factors. Genetics might account for around 50% of the risk, our sources suggest.
50%. Wow.
And then all the environmental stuff interacting with that biology. Social pressures, stress, early experiences, socioeconomic factors.
And the way some substances work, like nicotine hitting the brain so fast.
That makes a huge difference.
Yeah.
10 seconds for nicotine, it's incredibly reinforcing. And we talked about how withdrawal activates stress and anxiety circuits, making it physically and emotionally grueling.
So many factors working against you.
It really is a complex interplay. And because those brain changes last, relapse is always a risk. Effective strategies really need to hit it from all angles.
You need to address the physical dependence, maybe with medication.
But also the learned behaviors, the thought patterns, emotional regulation, the environmental triggers.
Yeah.
You need new coping mechanisms. It has to be multi-pronged.
Okay, that gives us a really solid foundation on the general science. Now let's maybe zoom in on nicotine and alcohol specifically. How do these principles play out there?
Sounds good. Let's start with nicotine, whether from traditional cigarettes or increasingly vaping. Nicotine is the main psychoactive compound, the addictive driver.
And the basic mechanism is similar for both smoking and vaping, that interaction with the nicotine receptors in the brain.
That's right. Nicotine binds to these nicotinic acetylcholine receptors, NACHRs, especially a subtype called alpha-4 beta-2, and as we said, the rapid absorption.
Leads to that quick dopamine hit in the reward pathway.
Exactly, reinforcing the behavior. But the brain fights back, adapting over time.
That's the tolerance and withdrawal kicking in again.
Yep, those receptors get upregulated, more of them, and desensitized. So you need more nicotine for the same effect, and you feel withdrawal when levels drop. Nicotine also messes with other neurotransmitters, like GABA and serotonin, affecting mood and anxiety, and impacts various brain regions.
And the health risks of smoking are just undeniable.
Absolutely catastrophic.
Yeah.
It's the leading cause of preventable death. The good news is, quitting at any age brings huge health benefits.
Okay, but vaping, it's often positioned as safer, right? What's the story with its addictive potential? It seems different.
There are some really unique aspects, yes. Modern vapes, especially those using nicotine salts, can deliver incredibly high nicotine levels.
Higher than cigarettes, even.
Sometimes equivalent to multiple packs a day, yeah. And it's often easier and more discreet to use frequently, almost constantly for some.
So people might be getting way more nicotine than they even realize.
That's a real concern. Plus, you have the appealing flavors, particularly drawing in younger people and masking the harshness of nicotine.
And that perception that it's less harmful might make people less motivated to quit.
Exactly. There's also the issue of dual use, using both cigarettes and vapes, or people just switching their dependence from smoking to vaping rather than quitting nicotine altogether.
So quitting vaping might be just as hard, or maybe even harder than quitting smoking.
The evidence suggests that yes, especially with these high nicotine products, it might require just as much, if not more, support. That's a crucial point.
Okay, very important. Now, shifting to alcohol use disorder, AUD. This isn't just about occasional overindulgence, is it?
No, AUD is defined by an impaired ability to stop or control alcohol use despite negative impacts on your life. And it exists on a spectrum, from mild to severe.
How does alcohol affect the brain compared to nicotine?
It's also complex. Initially, it boosts the reward system, dopamine, opioid receptors, giving that feeling of pleasure or euphoria. It also initially dampens brain stress systems, which can reduce anxiety temporarily.
But that changes with chronic heavy drinking.
Drastically. Tolerance builds. Withdrawal symptoms emerge. And interestingly, during withdrawal, those brain stress systems actually become hyperactive, leading to anxiety, dysphoria, negative emotions.
So the motivation shifts again from seeking pleasure to avoiding that horrible withdrawal feeling.
Exactly. It becomes driven by negative reinforcement. And long-term heavy use is neurotoxic. It damages brain areas involved in motivation, memory, decision-making, impulse control, those critical executive functions.
You mentioned it's a spectrum, so not everyone who struggles with alcohol fits the most severe category.
Correct. The official diagnosis, using DSM-5 criteria, looks at things like preoccupation, continued use despite harm, compulsion, loss of control, withdrawal. For moderate to severe AUD, abstinence is generally the recommended goal.
But for less severe cases,
There's growing recognition that reducing consumption to low-risk levels following guidelines like those from NIAA can be a valid and achievable goal for some people with problematic drinking patterns.
that might make seeking help feel a bit less all or nothing for some.
It could, yeah. And the health consequences of heavy drinking are just so widespread. Liver, heart, cancers, pancreas, immune system,
Yeah.
providing very strong reasons to quit or cut back significantly.
Okay, so we have the science for both the general picture and these specific substances. Let's pivot to actually making a change. Where does someone even start if they're thinking about quitting? Preparation seems key.
Preparation is absolutely vital, and a really useful way to think about the journey is the stages of change model.
Ah, yes, the Prochaska and DiClemente model. Pre-contemplation, contemplation. All the stages.
Exactly. It views change not as a single event, but as a process. Starting with pre-contemplation. You're not really seeing a problem, not thinking about changing within, say, the next 6 months.
What helps someone in that stage?
Gentle consciousness raising. Exploring potential risks, maybe personalizing them a bit without being pushy.
Then comes contemplation. You're aware there's a problem, you're weighing the pros and cons of changing, but you're ambivalent.
Right. The key here is resolving that ambivalence. Really digging into the pros and cons of both continuing the habit and quitting. Focusing on the positive outcomes of change.
Next up, preparation. Now you're committed, planning to take action soon, maybe within a month.
This is where concrete planning happens. Setting a quit date, identifying obstacles and how you'll overcome them, gathering support, maybe making small preparatory steps.
And then the big one, action. You're actively modifying your behavior, changing your environment. Sounds intense.
It is. It requires the most effort, and the risk of relapse is highest here. You're implementing the plan, managing cues, building self-belief, dealing with a sense of loss sometimes.
After action comes maintenance, right?
Yeah.
Sustaining the change long term.
Yes, typically defined as longer than 6 months. It's about consolidating those gains, preventing relapse, reinforcing the internal rewards of being free from the habit.
And the model includes relapse as a stage too, which is interesting. Not as failure, but
It's a learning opportunity, chance to figure out what triggered the slip, reassess your motivation and strategies, and get back on track, maybe with stronger coping skills. People often cycle through these stages. It's rarely perfectly linear.
that's so important. Normalizing relapse and ambivalence and matching your strategy to your stage.
Absolutely. Trying to force an action plan on someone in pre-contemplation just won't work. You need to meet people where they are.
Okay, so understanding your stage is step one. What are other concrete preparation steps?
Identifying your personal triggers is non-negotiable. What people, places, feelings, situations reliably spark that urge to use.
Like being a detective of your own behavior patterns.
Exactly. You can even use worksheets, mapping the cue behavior result loop. Triggers fall into categories: environmental, emotional, physiological, like withdrawal, even certain thoughts. If you don't manage these, they will drive cravings.
Once you know your triggers, you can set goals, but they need to be SMART goals, right?
Yes. Specific, measurable, achievable, relevant, and time-bound. Not just, I'll vape less, but I will not vape in the car.
Focusing on behavior rather than just the outcome.
Right. And breaking big goals, like total abstinence, into smaller, manageable steps helps build confidence, that self-efficacy. For alcohol, as we said, moderation could be a SMART goal for some.
And you absolutely need tools ready for when cravings or stress hit hard.
Definitely. Developing coping mechanisms in advance. Behavioral ones. Distraction, avoiding triggers, delaying the urge, replacing the habit with something healthy.
Like going for a walk instead of reaching for a cigarette.
Exactly. Then there are cognitive strategies. Challenging those negative thoughts. I can't handle this. Reminding yourself of your reasons for quitting, positive self-talk.
And physiological strategies.
Things like deep breathing exercises, getting some physical activity, staying hydrated, mindfulness or meditation techniques. Those 4Ds are a great shorthand. Delay, deep breathe, drink water, distract. Some add a 5th D. Discuss, talk to someone.
Practicing these before the craving hits seems crucial.
It really is. So you're not trying to figure it out in the heat of the moment.
Okay, stage identified, triggers mapped, SMART goals set, coping skills practiced. What pulls it all together?
A quit plan. Actually, writing it down increases your chances significantly.
That goes into a good quit plan.
Key elements include setting a specific quit date soon, but maybe not during a super stressful time. Listing your personal reasons for quitting. Identifying your triggers and planning how you'll cope with them and withdrawal. Cleaning your environment. Getting rid of cigarettes, vapes, alcohol, paraphernalia. Arranging support from friends, family, or professionals. Planning activities for the quit day itself and the challenging days that follow. And building in rewards for milestones.
And it's not set in stone.
No, think of it as a dynamic guide. You need to review it, adjust it as you learn what works and what doesn't.
Okay, great. Preparation is done. Now let's talk about the actual therapies and supports available during that crucial action phase. CBT comes up a lot.
Yes, cognitive behavioral therapy. It's based on the idea that our thoughts, feelings, and behaviors are all interconnected. If you change your thinking patterns, you can change how you feel and what you do.
So it helps you figure out why you use and how to react differently.
Exactly. It helps you identify triggers, then analyze and challenge the unhelpful thoughts that pop up. That's the ABC model. Activating event, beliefs, consequences. It teaches practical coping skills for cravings, stress, social pressure, and develops relapse prevention plans.
Breaking that automatic link between trigger and use.
Precisely. Catching the thought, checking it, and changing it. And the skills are super useful for life in general. You can do CBT one-on-one or in a group setting.
What about motivational interviewing? You mentioned that helps with ambivalence.
Yes, MI and motivational enhancement therapy, MET. These are really collaborative, person-centered approaches. The therapist doesn't tell you what to do. They help you explore your own reasons for wanting to change, your values, and any discrepancies between your values and your current behavior.
So it helps build that internal motivation.
Exactly. Uses principles like ROL. Resist telling people what to do, understand their motivation, listen empathetically, and empower them. And techniques like OARs. Open questions, affirmations, reflections, summaries. The goal is to elicit change talk from the person themselves. Hearing yourself say why you want to change is powerful. It respects autonomy.
And then there are mindfulness-based interventions. How do they fit in?
Mindfulness is about paying attention to the present moment, non-judgmentally. In addiction treatment, it helps you become aware of triggers and cravings as they arise, but crucially, to observe them without automatically reacting.
Creating a pause between the urge and the action.
Exactly that. You learn to notice the craving, the thoughts, the physical sensations without getting swept away. Just observing it, like watching clouds pass. This reduces impulsivity and helps manage stress and negative emotions, which are major relapse triggers. It cultivates self-awareness and allows for conscious choice.
Okay, so therapies tackle the psychological side. What about the physical dependence? That's where medication plays a role, isn't it?
Absolutely. Pharmacological support can be a game changer, especially for managing withdrawal and cravings for nicotine and alcohol.
For smoking and vaping, NRT nicotine replacement therapy is pretty common.
Yes, NRT gives you nicotine without the tar and toxins. It eases withdrawal, reduces cravings, and studies show it increases quit rates by like 50–70%.
Lots of options there, patches, gum.
Right. Patches provide a steady dose, while gum, lozenges, inhalers, and nasal sprays offer faster relief for breakthrough cravings. Combining a patch with a short-acting form is often the most effective strategy. Using it correctly for long enough, often 6–12 weeks or more, is key. For vaping, dosing can be tricky, you estimate, based on previous use.
And beyond NRT, there are prescription meds.
Two main ones for nicotine. Bupropion, originally an antidepressant, helps reduce cravings and withdrawal, maybe by boosting dopamine and norepinephrine. Might be particularly good if you also have depression.
And varenicline. That one sounds interesting.
Yeah, varenicline, brand name Chantix or Champix. It's a partial agonist. It partially stimulates nicotine receptors to ease withdrawal, but also blocks nicotine from binding fully, reducing the reward if you slip up. It's highly effective for smoking and showing real promise for vaping, especially in young adults.
But they have side effects and aren't for everyone.
Correct. Both need careful screening and monitoring by a doctor. Bupropion has warnings about neuropsychiatric effects and seizures. Varenicline also has potential neuropsychiatric side effects and maybe some cardiovascular risk, though that's debated. A conversation with a healthcare provider is essential.
So for vaping, even without specific FDA approval, these smoking cessation meds are being used off-label.
Yes, NRT, bupropion, and varenicline are all used. It's an evolving area, but combining behavioral support with medication seems most promising.
Okay. What about medications for alcohol use disorder?
There are three main FDA-approved meds: naltrexone, acamprosate, and disulfiram.
How do they work?
Naltrexone blocks opioid receptors, reducing the rewarding effects of alcohol and cravings. It comes as a daily pill or a monthly injection. Acamprosate helps stabilize brain chemistry disrupted by chronic drinking, reducing protracted withdrawal symptoms like anxiety and insomnia. Disulfiram is different. It's a deterrent.
How so?
It blocks an enzyme involved in breaking down alcohol. If you drink while taking it, you get a very unpleasant physical reaction: flushing, nausea, vomiting. It creates a strong aversion.
So different mechanisms for different goals.
Exactly. Naltrexone and acamprosate reduce the appeal or discomfort. Disulfiram enforces abstinence through negative consequences. Again, medical supervision is crucial for all these.
And like with nicotine, these are best used with therapy.
Absolutely. The strongest evidence from CDC, WHO, everyone, shows that combining medication with behavioral therapies gives the highest success rates for both smoking cessation and AUD. Meds address the physiology, therapy addresses the psychology and behavior. It's a synergistic effect, the gold standard when possible.
We've talked a lot about therapists and doctors, but what about the power of just support from other people?
It's huge. Behavioral counseling, whether individual, group, or via telephone quit lines, is proven effective.
What are the differences?
Individual offers personalized, deep work. Group therapy provides peer support, shared learning, you see you're not alone. And quit lines, like 1-800-QAT-NOW, are amazing, free, accessible, confidential phone counseling. Multiple calls are really effective.
What do they typically cover in counseling?
Assessment, building that quit plan, problem-solving skills, education about addiction, relapse prevention, building social support. Even brief advice from your regular doctor can prompt a quit attempt.
And technology offers support now too, right? Apps and things.
Definitely. Digital interventions are scalable and accessible. Smokefree.gov has the Quit Start app and Smokefree TXT. Truth Initiative has the EX program, and This Is Quitting, a text program specifically for young vapers.
What do these apps and texts do?
They offer tailored tips, progress tracking, help managing cravings and moods, educational content, links to other resources. Text messaging has particularly strong evidence supporting its effectiveness for quitting smoking. Apps are promising too.
Convenient, just-in-time support.
Exactly. Though keeping people engaged can be a challenge.
And then there are mutual support groups, like AA.
Alcoholics Anonymous is the most well-known. It's a peer-led fellowship based on the 12 steps and 12 traditions. It's free, anonymous, widely available.
Is it effective?
Research, including major reviews, shows AA can be as effective, or sometimes more effective, than other treatments like CBT in promoting continuous abstinence, especially with higher attendance. It offers long-term social support, structure, community.
But it's not for everyone.
No. Some find the spiritual aspect challenging, though higher power is interpreted broadly. The emphasis on powerlessness doesn't resonate with everyone, but its effectiveness for many likely lies in that strong community and long-term support network.
Are there secular alternatives?
Yes. Groups like Smart Recovery, which uses CBT principles, Life-Ring Secular Recovery, Women for Sobriety, and faith-based ones like Celebrate Recovery exist too. Plus, many community-based treatment programs offering accessible local services.
So lots of options. If someone feels lost, where's a good starting point?
Those national helplines and websites are fantastic first stops. They offer free, confidential info and referrals.
Can we list a few key ones?
Sure. For smoking vaping, 1-800-QAT now connects you to your state quit line, and smokefree.gov has apps and web resources. For substance use generally, Sam HSE's national helpline is 1-800-662-HELP-4357, and their website, findtreatment.gov, helps locate providers.
What about alcohol specifically?
The NIHE Alcohol Treatment Navigator, available online, helps find evidence-based care.
And for young people?
TruthInitiative.org has great resources, especially for vaping. The American Lung Association, ALA helpline, is 1-800-LUNGE-USA, and the 988 Suicide and Crisis Lifeline can also help with co-occurring substance use issues. These are great places to explore options.
Okay, let's circle back to vaping specifically for a moment. Quitting sounds like it has some unique hurdles.
It really does. That high nicotine delivery from salts, the ease and frequency of use, those appealing flavors, the social norms among young people, the lower harm perception, it all contributes. And the products vary so much in nicotine content.
So quitting cold turkey might be extra tough for a heavy vapor.
It can be. For those with high dependence, a nicotine tapering schedule might be a good strategy.
How does that work?
You gradually reduce your nicotine intake. You could switch to e-liquids with lower nicotine concentrations, maybe stepping down every few weeks. Or reduce how often or how long you vape each time. Some use NRT patches or gum to help manage cravings during the taper.
Needs a plan, though.
Yes, ideally a structured plan, maybe over 10-12 weeks or more, developed with professional guidance and combined with behavioral support. Needs to be personalized.
And the behavioral strategies for vaping, are they different from smoking?
Many overlap managing triggers, coping with cravings, using those 4Ds or 5Ds, preparing for withdrawal, building support. But vapers might need to specifically address triggers related to the device itself, the hand-to-mouth action, or those specific flavors. Social media influences might also be a bigger factor for younger vapers.
And medication for vaping is still off-label use of smoking meds.
Correct. NRT, bupropion, varenicline are used. Estimating NRT dosage can be tricky. Varenicline showed good results in one study with young adults. A newer drug, cytisinicline, related to varenicline and approved elsewhere, also looks promising. But again, needs discussion with a doctor about risks and benefits. More research is really needed here.
And there are specific programs for young people trying to quit vaping.
Yes, thankfully. Truth Initiative's This Is Quitting Text program is very popular. The ALA has school-based programs like Not on Tobacco and In-Depth Day. Smokefree.gov has smoke-free teen resources. Addressing peer pressure, social media, stress, and harm perceptions is key for this age group. Combining counseling or tech support with medication for older teen young adults where appropriate, plus involving parents, seems most effective.
Okay, we've covered quitting strategies. Now the tough part, withdrawal. What should people expect when they stop nicotine?
Nicotine withdrawal usually starts within hours, peaks around day 2 or 3, and fades over days or weeks, although cravings can linger much longer.
Symptoms.
Intense cravings, irritability, anxiety, trouble concentrating, feeling down, insomnia, increased appetite or weight gain, headaches, fatigue, maybe some coughing as your lungs clear out. Similar for smoking and vaping, intensity depends on dependence level.
How do you manage that?
Pharmacotherapy, NRT, bupropion, varenicline helps a lot with the physical side. But those behavioral and lifestyle strategies are crucial too. The 5Ds, delay, distract, deep breathe, drink water, discuss. Physical activity, healthy eating, good sleep habits, avoiding triggers, managing stress, and being kind to yourself.
Now, alcohol withdrawal. That sounds potentially more severe.
It absolutely can be. Alcohol withdrawal syndrome, AWS, occurs when someone stops or drastically reduces heavy, prolonged drinking. It ranges from mild anxiety, insomnia, tremors, nausea to severe and potentially life-threatening.
Severe like how?
Hallucinations, seizures, which can happen within 24 hours, and delirium tremens, or DTs. DTs usually appear 48-96 hours after the last drink and involve severe confusion, agitation, fever, racing heart, heavy sweating. It's a medical emergency with significant mortality risk if untreated.
So medical help is essential.
For moderate to severe withdrawal, absolutely. Assessment tools, like the CIWA-R scale, help gauge severity. Medications, primarily benzodiazepines like diazepam or lorazepam, are used to manage symptoms and prevent seizures and DTs. Supportive care fluids, electrolytes, thiamine to prevent brain damage. A quiet environment is also vital. Anyone with a history of heavy drinking needs to talk to a doctor before stopping suddenly. Medical detox is the safest way.
And even after the acute phase, there can be lingering symptoms. Pause.
Yes, post-acute withdrawal syndrome. These are symptoms that can persist for weeks or months after stopping nicotine or alcohol as the brain slowly recalibrates. It's not an official diagnosis, but it's a recognized phenomenon.
What kind of symptoms are we talking about?
Things like mood swings, irritability, anxiety, depression, sleep problems, fatigue, trouble concentrating, sensitivity to stress, ongoing cravings, sometimes feeling flat or unable to experience pleasure, anhedonia. They often come and go, sometimes triggered by stress.
How do you cope with PODIR?
Knowing it exists is step one. Education helps normalize it. Then, identifying patterns and triggers, maybe through journaling. Prioritizing self-care, healthy diet, regular exercise, good sleep. Managing stress with mindfulness or other techniques. Having a structured routine helps. Leaning on support systems. And tons of patience and self-compassion. Professional help if it's really persistent or severe. It's part of the brain's healing process. Managing pause is crucial for long-term recovery.
Wow. We have covered an incredible amount of ground today, from the deep brain science to very practical strategies and managing the aftermath. It's so clear that quitting these habits is incredibly complex.
It really is. And hopefully, understanding that complexity, the neurobiology behind it all, helps reduce some of the self-blame that often comes with struggling to quit. It's not just willpower.
Absolutely. And the encouraging part is the sheer number of evidence-based strategies and supports that are out there.
There really is a lot of help available. Behavioral therapies like CBT and MI, medications like NRT or naltrexone, support groups, digital tools, those helplines.
So for you listening, maybe take a moment to think about which of these resources could potentially fit your needs or the needs of someone you care about.
And remember, you really don't have to navigate this alone. Reaching out is a sign of strength.
So what does this all mean?
Well, I think it means that while quitting addictive habits is undeniably tough, it's far from impossible.
Right. Understanding the science behind it and knowing about the effective tools and supports available really does empower you to make lasting change.
It means there's hope, and recovery is achievable. Help is out there.
And finally, something for you to think about. Which specific aspect of the brain science or the psychology of addiction that we talked about today resonated most strongly with you? And based on that, what's one small, actionable step you could potentially take, maybe even today, to explore getting more support or starting to think about a change strategy?
That's a great question to ponder.
Thanks for diving deep with us.